Occupational English Test. Practice Test 4. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you will hear this sound. You will have time to read the questions before you hear each extract, and you will hear each extract once only. Complete your answers as you listen. At the end of the test, you will have 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for extract 1. Extract 1. Questions 1 to 12. You hear an A&E doctor talking to a patient called Sarah Chapman. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Miss Chapman. I'm Marie, the podiatrist here. How are you today?
Hi Marie, thank you for fitting me in. I'm not so bad. I didn't get a lot of sleep though, so I'm afraid I'm feeling rather tired this morning.
Oh no, I'm sorry to hear that. Is this a regular thing, not being able to sleep?
Yeah, unfortunately it is. It's my legs, they're keeping me up all night. I get terrible aches. Well, I say aches, it's more like cramp really, and the only thing that helps is standing on a cold floor. So I'm doing that all night, which is why I'm so tired recently.
I see. And is this why you've come to see me today?
Yeah, it is. It's just got to the point that I've had to do something about it because it's really affecting my sleep and my life, to be honest.
Okay, Miss Chapman. Have you seen anybody else about this problem?
No, I haven't. You're the first person. I come to podiatry every year for a yearly checkup and I'm due around now, so I thought that I'd book it in and see what you thought about it.
Okay. When did these pains during the night start?
A few weeks ago now. I thought it'd go away, but it didn't, and it's got to the point now that I'm hardly sleeping. I'm just always so tired.
Yeah. So it's affecting your quality of life really at this point, would you say?
Yeah, I would say so, yeah. I mean, now, during the day, I'm so tired that I can't do the things that I usually do. Not that I go to many places anymore, because, in truth, I'm finding it difficult to even walk. That's the other reason that I came to see you.
Okay, so you're getting the cramps during the night, and what is the reason that you're finding it difficult to walk at the moment?
Well, I've had trouble walking for longer than I've had trouble sleeping, and it's a similar pain. Cramps in my calves when I'm walking along.
Right, okay. So how far would you say that you can get as you're walking along before your calves start to hurt?
Oh no, not very far at all. It's very frequent and it never doesn't happen. So basically it happens every time I walk anywhere.
And is there anything that you can do to stop this pain?
Well, I just have to stop walking. That's the only way to get rid of it. But then it just comes back not long after I've started walking again. It's really getting me down and I just hope that you and your team can get to the bottom of why this is happening.
Well, I'm sure we can, Miss Chapman. First of all, I need to take a medical history from you, if that's okay.
Yeah, of course. What do you need to know?
Thanks. What's your date of birth?
14th of May 1952.
Okay. And are you on any medication?
Yeah, I'm on atorvastatin and metformin.
Okay. So am I correct in assuming from that medication that you have high cholesterol and type 2 diabetes?
Yes, that is correct. Well, I used to have high cholesterol. It's been successfully kept down by the medication. I had to go on metformin about a year ago.
Any other medical history that I should know about?
No, I don't think so.
Great. Do you or did you ever smoke, Miss Chapman?
I used to smoke, but I gave up around 10 years ago. I used to have around 15 a day, though, when I did smoke. Everyone did it when I was younger, so of course I did it as well. I did try and stop when I realised how bad it is for you, and I did finally manage it, and I haven't had one cigarette since.
That's excellent. Well done. Okay, well, the first thing that I think we need to do here is to get you an appointment with your GP. That would be to have a look at your medication, because the medication that you're currently taking for your cholesterol isn't really advised for people who have had or are currently suffering from muscle cramps. So, to do that, I will write to your GP surgery and explain that you have been to see me today complaining of cramps. After that, you should make an appointment to sort this out, sooner rather than later. Is that okay?
Yeah, I'll do that today. I had no idea. Thanks for picking that up.
Of course. So, if it's all right with you, at the end, I'll just confirm your GP details with you so that I make sure the letter gets to the right place.
Extract 2. Questions 13 to 24. You hear a GP talking to a patient called Roberta Foss. For questions 13 to 24, complete the notes with a word or a short phrase. You now have 30 seconds to look at the notes.
Thank you, Miss Ross, for being so patient. As you know, we need to complete a pre-assessment screening and we have a few more questions.
Yeah, sure, go ahead.
I understand that you suffer from obstructive pulmonary disease, or COPD, and you are a lifelong smoker of 16 cigarettes per day?
Yeah, unfortunately, that's right.
And I understand that you use inhalers daily. Apart from mild hypertension, you also have evidence of coronary heart disease?
Yeah, I mean, that's what they told me. I don't really know, to be honest. I believe so, yeah.
Okay. Do you use home oxygen?
No, I don't.
And do you have any other issues, any medical problems that you need to disclose?
Yeah, actually I do. I don't know whether this is, classed as a medical problem, but I can't walk very far before I start getting breathless. I can only really go about 30 yards, and then yeah, I do get out of breath quite quickly.
Okay, and have you ever been admitted into hospital or intensive care unit with breathing problems?
Just off the top of my head, I've been in hospital 3 times. I've had 3 hospital admissions in the last 5 years, but no ICU stays, no.
Okay, that's good. Regarding your recent examinations, your vital signs were fine, except for your blood pressure, which was raised at 148/92. Now, your oxygen saturations are 93% on room air, and when I listened to your chest, I could hear moderate air entry with some scattered wheezy sounds.
Okay, so what do we do next?
Okay, so we're going to do a few tests. We will need to do an up-to-date x-ray, an arterial blood gas to establish your baseline bloods, and some basic respiratory function tests, like spirometry. Do you know what any of these are?
I know what the X-ray and blood gas are. What's this spirometry?
Spirometry is a timed measurement of different lung volumes when you force expiration.
Okay.
It gives us all kinds of useful information about how well your lungs are working. It can tell us if your airways are restricted or if you have disease deep within your lungs, for example.
Oh, okay then.
Now, I'm aware that you've had smoking cessation advice before.
Many times, but to be honest, I think I'm a bit too far gone at this point.
It is really important that you give up smoking prior to the surgery. I know you've probably heard this already, but evidence shows that if smokers give up smoking at least 6 weeks before surgery, it carries benefit to patients with lung and heart disease especially.
Oh really? Like what benefits?
Well, there's a reduction in mucus secretion in the lungs, small airways narrowing, and improvement in the ability to clear secretions. Now, you may know that smoking increases carbon monoxide levels and nicotine in the blood, which increases heart rate and blood pressure, which lead to increased cardiac stress during surgery. Now, this can be significantly improved if smoking is stopped, even just for 1 day before surgery. So, if it's okay, I will refer you to the nurse for further details on smoking cessation.
All right, yeah, fine. Right, doctor, thank you.
Okay.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare setting. For questions 1 to 6, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete your answers as you listen. Test 4. Now look at question 1. You hear a presentation on nutritional physiology. Now read the question.
Nutrition physiology deals with the various kinds of food and the effect it has on the metabolism. The importance of nutrition during development and growth and aging is appreciated in human medicine. Also, it has become increasingly obvious that human health is largely dependent on a functional and healthy gut. And many modern diseases such as stroke, heart disease, diabetes and cancer are related to gut physiology and to the diet. Hence, nutrition physiology deals with the extraction of nutrients from food by the body, how the needed energy is obtained, how the nutrients is utilized, and its relationship to health and disease. Research conducted recently has shown that gene regulation can be affected by the environment via several other mechanisms than described with traditional genetics. Hence, nutrition has a great impact on the development of chronic and lifestyle ailments, such as atherosclerosis, diabetes, and obesity. How pathological conditions progress can be observed through changes in cellular functioning and signaling, with consequences for a number of physiological processes.
Now look at question 2. You hear a team of dentists discussing the acquisition of a new chair. Now read the question.
Really sorry, but this chair's absolutely had it. The whole time the patient was telling me about their flossing habits, all I could think was that I hope they don't fall out of this chair.
I know, it's embarrassing really. It's just that we bought all of the chairs, there's a lot, and I can't bear the thought of throwing them away.
Not all of them, just this one. See, look, this button doesn't even work anymore. It just sits there, not doing anything. Look, I know you don't necessarily want to fork out for a new one, but just take a look at this. The Chievo 350 full-spec dental chair. It does everything. Seriously, take a look.
What are we looking at?
A fully ergonomic chair with 5-handpiece hanger delivery system, multifunction foot control pedal, large and small bore suction hose and 10-function panel, built-in spittoon in glass or ceramic plus fibre stitched leather.
Say the word and we can have it tomorrow.
Brilliant. Then we can throw out this old, mouldy one.
Oh, I don't know.
Come on, you've not even got to the built-in intoral camera yet. We can even customize it to the practice colours.
Just look at the delivery fee.
Well, it's coming from Luxembourg.
Oh, don't you start and all.
Now look at question 3. You hear a podiatrist discussing a condition. Now read the question.
One of the major complications of peripheral artery disease, or PAD, is a painful ache developed by sufferers in their legs when they walk. The medical term for this is intermittent claudication, and whilst it usually disappears after a few minutes of rest, it re-emerges moments later, i.e. the pain is intermittent. It is usually the result of either a blockage in the artery or a thickening of the artery wall. The pain can range from mild to severe and usually goes away after a few minutes when you rest your legs, hence it can be colloquially known as rest pain. Both legs are often affected at the same time, although the pain may be worse in one leg than the other. Treatment for intermittent claudication includes aspirin, exercising regularly and stopping smoking if you smoke. These are the main lifestyle changes that can ease the symptoms of PAD and reduce the chances of the condition getting worse.
Now look at question 4. You hear a vet discussing a vaccination. Now read the question.
It's always a little awkward giving a vaccination to a well-loved pet, especially if the children are involved. I always take time to explain step by step everything that's happening because they don't want to think their pooch is in pain. Just last week, I had a really tricky scenario. The family had brought 6-month-old Monty from Australia, and he was in a really bad way. He had a fever, his jaw was drooped, and he wouldn't swallow anything. I did a blood test to be sure, but it was obvious that he had rabies. Thankfully, the family had brought proof of canine insurance, so treating Monty was relatively straightforward. I even sent a blood sample off to an EU laboratory just to be sure. The results will be back before the end of the month, and I fully expect that he'll be given the all clear. I also, as a preventative measure, advise the family to go to their GP. Rabies can be fatal to humans, and vaccination after exposure is highly successful in preventing the disease, but only if we act quickly.
Now look at question 5. You hear a team of optometrists preparing for a conference. Now read the question.
What do you think about when I ask you about managing glaucoma on a daily basis? That's right, you think about changes to lifestyle, changes to daily routines like the time you wake up, meal times and bedtime. The glaucoma medication makes a huge change to every aspect of your day and, more importantly, to your life. Those are the main changes to your physical life, but a lot of people overlook an often neglected aspect of glaucoma treatment. Does anyone have any idea what that is?
What are you doing?
You scared me. I'm just preparing for the conference.
Conference?
The London project to cure blindness. I'm one of the speakers.
Good for you. I take it your topic is glaucoma management.
Yes, and its effect on day-to-day life.
Can I come, grab a front row seat?
If you'd like to.
Now look at question 6. You hear a group of radiographers discussing some X-rays. Now read the question.
Can we really justify this gratuitous spending?
Excuse me, I don't think X-ray backscatter imaging is gratuitous. On the contrary, I think all this time that we haven't had the capability has made us look like dinosaurs in our industry.
Dinosaurs? Hardly. I mean, I understand that we need to be able to carry out less destructive examinations.
Exactly. Just imagine what that will do for our credibility. Our hospital clients will be very supportive of procedures that carry less risk.
She's got a point.
I know she's got a point, Jane, but you're talking about £11,000 when we're not even sure that much of a difference.
Much of a difference? Of course it will. A typical X-ray image is black and white and in 2D. What we're talking about here is potentially revolutionary. We're one step away from 3D printing here.
3D printing X-rays?
I really think that the savings we'll make in the long run would make this a really good investment.
That is the end of part B. Now look at part C. Part C. In this part of the test, you will hear 2 extracts. In each extract, you will hear health professionals talking about aspects of their work. For questions 7 to 22, choose the answers A, B, or C, which best fits according to what you hear. Now look at Extract 1. Extract 1, questions 7 to 14. You hear a psychiatrist, Justin Harrisberg, giving a lecture on mental health. You now have 90 seconds to read questions 7 to 14.
My name is Dr. Justin Harrisberg, and I'm a mental health professional specializing in psychiatric well-being. My topic today is an increasingly important issue: clinical depression and mental health awareness in adults. Clinical depression in the UK is becoming an increasingly difficult problem, both socially and economically. And in 2014, a national survey found that 20% of adults aged 16 and over displayed signs of depression or anxiety disorder. Depression is unlike most illnesses, however. It can display a variety of symptoms, both physical and mental, which usually differ from patient to patient. This can make depression a complex illness to diagnose, and even more difficult to effectively treat. The most common means of treating depression is to prescribe antidepressants. In the UK alone, 65 million items of antidepressants were prescribed in 2016, almost 4 million more than the previous year. This treatment is most effective when combined with adequate lifestyle changes and mental health therapy. Despite this, however, therapy is rarely used in NHS therapy. In 2016, 60% of depression cases were treated at some level, although only 12% received any psychological therapy. The process is often long and involves discovering the root of the cause. Average treatment time for depression is almost 6 years. The most disturbing statistic to be drawn from this is that of those patients suffering from a form of clinical depression, 40% go without any form of treatment. This is in large part due to the negative social stigma that regularly accompanies mental health diagnosis. As previously stated, depression is an illness with many different variations. Patients can experience dramatic highs and lows, or feel slightly down for extended periods. The nature of the illness, therefore, affords it a negative perception, with depression often being viewed as an unreliable or artificial illness. Many people still to this day in the UK view depression as a made-up illness, and something you should be able to simply snap out of. This could not be further from the truth, but it is the perception of depression that holds certain sufferers in fear of speaking out. A refusal to seek out any help continues to lead to a significant problem: suicide. Suicide in the United Kingdom is strongly correlated with mental health illnesses. There were 6,122 suicides in 2014 of adults aged 10 and over. Approximately 90% of those suicide attempts were undertaken by a person suffering from some form of mental health disorder. Suicide as a direct result of depression is a reality the NHS must do more to confront. There is clear evidence to suggest that mental health treatment does not do enough to address the issue. For example, from 2003 to 2013, there were over 18,000 suicides whereby the victim had previously had mental health service contact within the UK. In that time, it was concluded that 75% of all mental health patients did not receive adequate treatment for their specific illness. Evidently, a very real problem exists. A further dimension is added to the crisis when we break down the demographics of those who are taking their own lives. Of the people who have committed suicide due to their depression, 75% are male. Of adult males below the age of 50 in the UK, suicide remains the biggest killer. This can be linked again back to the social stigma associated with mental health and specifically depression. Until the stigma is tackled head-on, young women and especially young men will be too ashamed to consistently come forward. Once this perception of mental health is altered, mental health illness can be more adequately tackled.
Now look at Extract 2. Extract 2. Questions 15 to 22. You hear a doctor, Francis Hines, giving a presentation on Alzheimer's and early onset dementia. You now have 90 seconds to read questions 15 to 22.
Hello, my name is Dr. Francis Hines, and I'm a general practitioner and family advisor who specializes in Alzheimer's and early onset dementia. My topic today is an increasingly important issue, both socially and economically, within the UK healthcare system: Alzheimer's and the impacts it has on life. Alzheimer's disease is the most common form of dementia in the UK, a disease which 850,000 residents suffer from. Alzheimer's is a progressive syndrome whereby the symptoms become far worse over time, and brain functions are significantly affected, leading to loss of memory, language, and other mental cognitive tasks. Dementia is one of the most common diseases in the UK and affects approximately 225,000 new people every year, about 1 every 3 seconds. Although there are no causes that directly lead to dementia or Alzheimer's, there are certain situations under which you are more prone to develop the disease. The first and most obvious cause of Alzheimer's is old age. 1 in 14 UK residents over the age of 60, and more alarmingly, 1 in 6 people over the age of 80 in the UK will suffer from some form of dementia, and most will have Alzheimer's. It is not a disease, however, that is strictly confined to the older population. There are approximately 40,000 people in the UK below the age of 65 who have Alzheimer's. This is known as early onset Alzheimer's disease and has similar effects as regular Alzheimer's disease. The UK in 2014 had a median population age of 40 years, rising from 33 years in 1974. This is a significant statistic as the UK population continues to age, thus meaning that Alzheimer's will continue to remain at the forefront of UK medical practice for the foreseeable future. Alzheimer's also has a significant economic effect on the UK. In UK care homes, 70% of inpatients are dementia or Alzheimer's sufferers. As of 2017, the cost of dementia to the UK economy stands at €26 billion, and that figure is set to rise to €55 billion by 2040. For a comparison, the cost of lung diseases to the UK economy is €11 billion, despite there being almost 12 times as many residents suffering from a lung disease than those who suffer from dementia. The majority of economic impact of dementia, however, is felt by the dementia sufferer and their family. These people pay for 2/3 of the total cost of dementia. This could be on anything from care homes, which cost an average of €40,000 per year for a home with a nurse, to nursing. Alzheimer's currently has no cure, and the deteriorating nature of the syndrome means that it takes a heavy economic and personal toll on the family who are affected. However, despite Alzheimer's significant impact on both the economy and patients who develop the syndrome, the UK government spends just €74 million annually on research, per a 2013 report. This is a worrying low sum when you consider that cancer research gets up to 7 times as much funding from the government. There is currently no long-term or clear plan in place to tackle dementia and Alzheimer's in the UK, and this must change as the reality is that neither syndrome will be going away anytime soon. One recommendation put forward by Alzheimer's trusts in the UK is to have a rise in the number of patients made available for clinical trials. The figure currently sits at 4%, but there have been calls for that number to rise to 10%. Given the strain and negative impact Alzheimer's plays on so many people's lives and wallets in the UK, such a step would be a good start to making what appears to be a long road ahead for the UK healthcare system.
That is the end of the listening test.